Welcome to day 2 of Uppsala Health Summit, New Pathways to Lifelong Mental Well-Being. Now, yesterday we got to hear about the big picture, the overall picture of this topic, and also learnings from the pandemic. And we got to hear about what UNICEF are doing for children and adolescents within mental health, and also other creative initiatives and insights. Today we will listen to experts in the field of innovations and strategies to find new ways in tightening the treatment gap. What can future of digital mental health tools, such as apps or artificial intelligence, give us? And how can we get help from animals? Maybe mankind's best friend, the dogs, for instance. Now, during this entire day, you can put questions in the chat if you want to, and we will try to answer some of them at least. So feel free to put your questions in the chat. First of all, I'd like to introduce Joanne Woodford. Welcome.
Thank you.
Now, researcher in clinical psychology and healthcare science here at the Uppsala University. Also an expert in e-mental health and part of the program committee here at Uppsala Health Summit. Now, today we're going to explore new innovative ways of treatment here today. And your research, I know, includes family mental health, both children and parents and other caregivers. What would you say on new digital tools together with different ages and different generations?
Yeah, I do work with different family groups across the lifespan. So I've worked with adolescents and young adults and e-mental health solutions for that age group, through to a lot of work with informal caregivers of older adults, so people with dementia and their family caregivers, for example. And I think that so in summary, e-mental health solutions can be suitable for people across what you might call generational cohorts. But one of the most important things to think about is how we can develop interventions that meet user expectations. So thinking really carefully about how we can enhance technical solutions to enhance the acceptability, meet different expectations that different user groups will have, and also reach out to those people who are maybe more excluded, digitally excluded. So not just talking about, say, older adult generations, but also people, for example, in our research, we very often recruit very specific populations. So often we're not necessarily recruiting people from lower income backgrounds or people with lower levels of education, for example. So yeah, I think the main focus should be on how we can develop interventions that meet expectations of users.
So you need to do different tools for different target groups then, maybe?
Yeah, working really closely with the groups of individuals who we're developing interventions for.
I see.
Doing that in a better way.
Yeah, adjusting them for them. Yeah, thank you so much. And you will stay on a bit today. But now, please welcome our first speaker for today, Dr. Andy Blackwell, Chief Scientific Officer at IESO Digital Health in the UK. And Andy, you work with how convergence of data availability and the novel computational methods can better target and give more effective treatments for mood and anxiety disorders. Now, rethinking the role of technology within mental health, I think you could say. We are eager to hear more about this. So welcome, Andy. The screen is yours.
Oh, well, thank you very much. It's a real privilege to join such an exciting meeting. My optimistic, I suppose, contention for these few minutes is that as we reflect on innovative strategies for closing the treatment gap, we may now have new opportunities to put technology to work and health system data to work, not only improving access, but also in improving quality. So I'm going to give a couple of examples of that. The conversation that we have when we talk about technology in mental health care has, in my experience for the last 20 years, primarily focused on access. We're often talking about apps or mental telecare or virtual care or remote care delivery. And whilst a few years ago those were a sort of exceptional part of the of various health systems, certainly in the last 24 months and during the pandemic, they've really become the mainstay of psychological therapies delivery. But I think there's also new opportunities to extend the role of technology beyond timely access. In almost every other industry, we have in the last 5 years begun to use data from previous decisions, actions, and outcomes to continuously improve the quality of products and services generally that we are bringing to people. But that hasn't really yet arrived in mental health care. And oftentimes, although there is a proliferation of these solutions, we have many virtual care solutions. I'll talk about the one that I'm most familiar with in a minute. And we have thousands and thousands of apps. People often find it hard and have long journeys of trial and error to find the right thing for them. So can we apply technology in helping people receive an accurate problem descriptor or a diagnosis? Of the many thousands of clinicians that may be available, can we use technology to help them find the person that they're most likely to be able to engage with and benefit from? To find the right type of treatment, be that software or a medicine or a human psychotherapist, for example, at the right dose and intensity of treatment. And perhaps can we also apply technology to ensure that active ingredients or meaningful components of care are being delivered in a reliable way so that people get an enduring benefit. So just as our satellite navigation systems, without which, well, we wouldn't be without them these days, would we? Use real-world data to enable smarter decision-making. My question is, can we attempt to learn from every person now that the care is virtualized and data are being captured, so that each person can find an optimal path to recovery? I think we can, and I'll give you some examples of that. So I've worked for the last few years with an organization called IESO Digital Health, which is based in the UK, principally in the IAPT system, which I know you guys will be very familiar with, improving access to psychological therapies, which is in NHS England in primary care. And we deliver a very high volume service. It's one-to-one, largely high intensity mental health treatment using a telecare platform, which is largely written correspondence between patients and therapists. It's both synchronous, so we have hour-long sessions of therapy, and asynchronous messaging between, so sort of text correspondence between sessions also, which we found to be very important. We've developed a number of computational methods. We've really had to apply various artificial intelligence techniques to be able to quality control the care as we've scaled our activities to many thousands of patients in treatment every day. And but like many of the providers in the UK, we have an integrated outcomes measurement framework, and many of our contracting arrangements with people that are procuring these services are based on a fee for value model. So we're paid a little to be engaging with systems and with patients, but we're also paid based on clinical outcome. One of the slightly unique things about our organisation is that we're based in Cambridge, and we have a clinical science laboratory inside the organisation. So we're continuously studying what's working and what's not. Those decisions, actions, and outcomes on a scale. So we've tried to sort of bring academia and care delivery into a high throughput environment. And just so you understand the sort of people that we're trying to help, like many outpatient primary care mental health systems, principally the most common condition is depressive episode, generalized anxiety disorder, and a range of other anxiety-related conditions. We are principally what in the IAPS lexicon, it would be referred to as a step 3 or step 3 plus provider. So our patients are mostly sort of moderate to severe in acuity. And we have around 6,500 patients currently in treatment at any time. And people stay in treatment on average for about 5 to 6 hours of engagement with their therapist. That's 5 to 6 synchronous hours of engagement. I know everybody on this call knows about IAPT and the outcomes measurement framework, so I won't labor on this. But we collect outcomes data at every session of treatment using very commonly used instruments such as PHQ-9 and the GAD-7 scale, and we are targeted and incented, I suppose, to deliver high quality outcomes and measured in the form of clinically reliable improvement and recovery, and we can come back to those definitions later if that's helpful. But as we're trying to understand what is working for whom on a very large scale, of course, it's really critically important to have some measurement of the clinical impact of those interventions. It is also key as we're trying to understand which actions and utterances that are exchanged between patients and therapists matter. What are those sort of active ingredients that we need to pay particular attention to? We've been faced by a previously almost intractable challenge, which is that, of course, most of the information about our mental health is encapsulated in the form of human language, and language is really hard to analyze and very laborsome to transcribe. So we've built some systems, one in particular, which we call the therapy insights model, which is a deep neural network based system. It's essentially natural language processing with recurrent neural networks underneath that approach, which is able to, in real time, code or turn from words into numbers the events that are occurring during a therapy session. So here, this rather colorful ribbon, of course, these models are very complicated and sort of multidimensional, but for simplicity here, I presented 1 hour of therapy with utterance by utterance. The model is detecting the type of language event that's occurring. So the first 8 minutes of that little ribbon, the computer is detecting principally chit chat. It codes it as other, so it's non-therapy related language. And there's about 25 minutes with these pink bars where the computer is detecting evidence-based change methods, so things like behavioral reattribution, change mechanisms. It can also detect when people are using empathy. So these systems have been trained using annotated transcriptions, and now they do that automatically and very accurately. And then at the end of the session, there's about 14 minutes of consolidation and planning and administrative tasks. So on average, we have discovered, we've analyzed now about 730 million sort of language events. There's about 28 minutes in every hour of therapy that's delivered that where we can sort of tie the activity to sort of known evidence-based procedures. So we can richly characterize the challenges that people are experiencing. We can understand the ingredients, what's happening in therapy, without manually having to code those things, and then we can study the outcomes, and that's really where we've been doing this for a few years, and there's a long way to go. But so some of the results we've published in a series of papers, and more to come soon. One in JAMA Psychiatry, we looked at 90,000 hours of therapist language, and we were looking to see which of these utterance classes, here you can see therapeutic praise and planning for the future, perceptions of change, use of change methods, whether they are in a very simplistic model associated positively or negatively with engagement in treatment and being able to stay in treatment to get a dose, and recovery, alleviation of those symptoms on the scales. And we've also looked more recently in about 180,000 hours of patient language to study what it is in patient dialogue that seems to be to announce whether people are going to benefit from the treatment that they're receiving. And so we're learning a lot now about how important the disclosure part of engaging in treatment is, and whether people are showing self-exploration and engaging with the activities that they're working through with the therapists. So we can use these approaches in a number of very practical ways. There are hundreds and hundreds of hours of therapy happening every evening. Most of our therapy is 6 till 10 p.m. Monday to Thursday. And we're now able to automatically process all of that and to turn it into content that we can give to our clinical supervisors, who are then able to think about how they help therapists reflect on what's been observed in those therapy sessions. And we're now moving into another period of really starting to understand the complex and sort of multidimensional relationship between patient, therapist, therapy type, clinical language factors, and outcomes, really to build a more comprehensive model of optimal behavior during a therapy session. We think there are loads of ways that we can translate that kind of insight into impact, and that's really, of course, the end game of all of this. And we're exploring more and more advanced sort of clinical decision support systems. To come back to our sat-nav analogy, maybe there are ways in which we can help people sort of stay on course, or give counsel in real time during sessions. That's very complicated to design those things, and of course, agency on the part of the therapist, and a range of other factors are just, there's lots of work to do there. But there is an opportunity for really fast cycle knowledge translation and sort of personalized treatment recommendations. We measure outcome in a particular cohort, so we use a sort of rejection sampling method to make sure we're comparing like from like over time. The graph on the right very simply shows our clinical recovery rates for generalized anxiety disorder and depressive episodes since 2013. We're currently tracking about 68% recovery rate through this year. And I think what this tells us, there's a multiplicity of reasons why those recovery rates are improving, but one of them is simply being able to monitor and scrutinize the quality of care that's being delivered and give people support in doing that. And really, the thing that excites me most is, as we get more data, we can learn, we can update guidance, we can verify and confirm multiple times the impact of any changes that we make, and hopefully that drives better outcomes for everyone. So my conclusion is, and I'm sorry, it's a fast run through, but that in thinking about closing the quality and access gap, we can maybe extend our thinking equally to think about quality as we do access, and really put technology seriously to work to those ends. And network level modeling of decision action outcome patterns really could, I think, improve the cost effectiveness of treatment. It might help through clinical decision support systems translate knowledge faster into impact, help maybe early career clinicians get some guidance in their practice, and as if they have a supervisor with them all the time, and really automate some. I think in terms of some of the machine learning frameworks, we may be able to automate time-consuming administrative tasks to really increase the dose of the important elements of therapy without overburdening an already scarce and precious clinical community. And ultimately, what we discover in these health system data with these new computational methods may help us to inform the design of more autonomous and scalable digital therapeutic systems that are more personalized and hopefully therefore more engaging and more effective. I'd just like to thank very quickly my a range of colleagues. We're about 140 people, about 800 clinicians, and of course all of the people that have been through the service and give us data so that we can learn to help other people better. So I will stop there.
Thank you so much. Thank you. A huge work that you do, really a challenge, and all that material must be, you're really working with that. And I have a question from the audience. How do you handle the privacy of personal data, and how long do you keep the information? Because you gather a lot of personal data.
Yes, that's of course a really important issue, and in fact it's taken several years in order to be able to put in place the appropriate information governance and procedures for consenting and so on. The part of the I think one of the rather wonderful things about the UK IAP system is that, in a sense, it has, from its inception and through the leadership of David Clark and others, enabled the data that are used in clinical practice to be applied for clinical audit, quality control, and so on. And we have added multi-layered consent procedures and other facilities to enable us to do where there is intervention as well as sort of observational work in these data. So it's a hugely important thing. And but I think it's just I think also there is an imperative to learn from these data. It also often feels to me that it's such a great shame that most telehealth care really immediately eliminates the data, and there's just it seems like we could do better, but of course it has to be done in the right way.
Yeah, thank you. This market is expanding hugely, and we get more and more different apps all the time on mental health, from dieting to really mental health quality products. What would you say? Is it good or bad with all these private providers for apps, for instance? How do you see this market?
I think I think it's amazing how quickly this field has evolved, and I think the absence of applications was a missed opportunity. I think sometimes now the proliferation of solutions has become part of the problem, and so helping people to find their way to something that is appropriate for that person, I think, is a new area of work that, as a field, we need to really invest in. I think if people find their way to their sort of something that's intended for people who have very mild condition, and they are in fact having moderate to severe conditions, it can serve simply to inoculate them against seeking help. But similarly, having a super intense intervention for somebody that could benefit from 5 hours of time with a psychological wellbeing practitioner, or we have to. I think we have to find ways of better targeting this vast array of new solutions and help people find their way to the thing that's going to work for them best. And again, probably the way to learn that, I think, is not in siloed laboratories with looking at a single application and looking at its particular effectiveness, normally in a per protocol analysis in a small scale clinical trial, but actually to look at these applications in widespread use. And then we should be able to infer for whom each application has an optimal benefit, rather than some of these rather caricatured discussions that happen with it's this versus that. I think the reality is, when you look in tens or hundreds of thousands of people, that many of these solutions work for a much smaller group of people in need than is on the label for them.
So find a way to help people navigate in this
I think that's right.
Yeah. Okay. Thank you so much. Stay on for a short panel discussion later on. But now I'd like to introduce our second speaker. Now, more and more research and studies are made in this, and the effects of artificial intelligence within the field of mental health, as we just said, and it's growing very fast. Here to tell us more about the potential of artificial intelligence to provide support for low-intensity CBT and providing a scalable solution to the continuing treatment gap is Paul Farrand, professor at the University of Exeter in the UK. Welcome, Paul. Are you with us?
I am indeed, or I think I am.
Excellent. Sorry, I saw someone else. Go ahead. Welcome.
Okay. Well, thank you for inviting me to this session. It promises a lot, and obviously this is a very cutting-edge group of research that we're talking about, and also hopefully solutions to some of the challenges that we're facing with mental health. So if you could move on to the next slide, please. So what I'm going to hopefully do is try actually in some ways pick up on the previous speaker's talk. And basically, we need to think about doing things differently. Mood disorders represents a public health challenge. Across the world, the majority of common mental health problems go unrecognized and they go untreated. And basically, the previous way of doing things actually isn't working. As part of that, the treatment choice for many services remains antidepressant medication. And there's nothing wrong with antidepressant medication. It's evidence-based. But as long as people choose that that's what they want. If they don't choose, then we have to have alternatives. And the alternatives that we know are already existent are evidence-based psychological approaches. We do have evidence-based psychological approaches, and this is driven by the evidence base. But often, and the previous way of delivering often resulted in very high costs of delivery. We had an expensive workforce. We had protocols that would suggest for depression, for example, 16 to 20 hours of treatment, CBT, for depression through the National Institute of Health and Care Excellence guidance in the UK. So we had the high cost of delivery on one side, and the other side of the high cost of delivery, the demand is we soon had waiting times for psychological therapy. And before the improving access to psychological therapies, in some parts of the United Kingdom, they were 12, 13, 14 months. And that's unacceptable. You're not offering a service there. So we needed to think about different ways of doing things. If you could move on to the next slide, please. So what we really needed was a revolution, not an evolution. We've tried to evolve mental health service delivery for a long period of time. And basically we didn't progress. So we needed a revolution, but that revolution isn't just talking about technology to support the delivery. It's actually talking about something far more fundamental in which technology can actually exist and be one of the solutions to demand and to choice. And that is the organization of care. And something that we realize within the Improving Access to Psychological Therapies program is the organization of care had to take in into account a few things. It had to take into account evidence-based psychological therapies and what's evidence-based for whom and what's evidence-based for the series of common mental health problems that present. And we did this by adopting something called Stepcare. And we're talking about this being implemented, as the previous speaker said, within the Improving Access to Psychological Therapies program, the model of which is now being considered in other countries. So I'm doing some work in the United States with certain states and in Canada most recently that are looking at some of the benefits of trying to improve access through a variety of mechanisms. So I'm going to go on and talk about Stepcare If we could move on, please. So stepped care really is a way of organising mental health service delivery. And the National Institute for Health and Care Excellence, for those of you who don't know what this is, it's a panel of experts who look at the evidence, grade the evidence, because as we know, there's a lot of so-called evidence out there, but actually once you start sifting it for quality evidence, then actually it drops away massively. So it's some of the challenges and some of the need to be able to grade and identify good from not so good quality evidence. But on the basis of evidence, NICE recommends the step care service delivery model. It's not the only one. There are matched care service delivery models, and there's some research done by people like Annemieke van Straten that's compared the two. But whilst there were no difference in outcomes, step care was recognized to be the cheaper way of delivering psychological therapies. According to stepped care, the treatment that people receive is based upon the severity, and this picks up on something that the previous speaker said. So we start to identify the severity of the presenting common mental health problems. So we classify those in terms of by the PHQ-9 and the GAD-7 for depression and anxiety, respectively, in terms of mild, moderate, and severe severity, because different evidence-based interventions reside at different levels of the step care model, and they're targeting both different disorders which are presenting and also different severities of the disorders. And then progression, you must be able to progress through the step care model because it's dependent on changes in severity and all the impact that the mental health difficulty has for the person. So one of the characteristics of step care is you must be able to progress up or down the step care model according to clinical need. And another characteristic of the step care model is we have a varied workforce. We don't have a one-size-fits-all workforce. So we've identified separate workforce, the competencies associated with different workforces to deliver psychological therapies at different steps of the step care model. So if we could move on the next slide, please. So this is the service redesign that we use in the improving access to psychological therapies. So we have different intensities of psychological therapies at the different levels. So minimal symptoms, step one, is basically dealt with in the community. And these are people who have sub-threshold levels of severity for the common mental health difficulties. Step two is the low intensity cognitive behavior therapy. And that's for mild to moderate presentations of depression and the majority of anxiety disorders, with the exception of social phobia and also post-traumatic stress disorder. There is no evidence-based step two intervention currently, so these would be escalated to where the evidence is at step three. And at step three, we have high-intensity psychological therapies, and that's for the moderate to severe depression and anxiety. And then at step four, that's where the treatment for severe and enduring mental health difficulties comes in. Now, what we have is different workforces at different levels. So we have a workforce, a psychological wellbeing practitioner workforce at step two. We have our high intensity classic therapy workforce at step three, or our clinical psychology workforce, which are increasingly delivering psychological therapies in the UK. And then at step 4 and 5, you start moving into psychiatry or specialist mental health nursing. Now, one of the characteristics of this is that step 2, low intensity CBT, is supported. The evidence base suggests it needs to be supported. It comes in the form of self-help interventions based on a CBT model. The self-help, the amount of support is reduced compared to high-intensity psychological therapy, which tends to be 50 to 60 minutes. So in terms of guided CBT self-help, we're talking about 25 to 35 minutes to support the interventions, and the therapy is delivered by the intervention and the psychological practitioner supports the patient using that intervention. So we have that specialist psychological practitioner workforce. But there's a slight challenge if we want to make a difference on a worldwide scale. And that's to do with, if we have a workforce, we have limits to scalability. Whilst it's a cheaper workforce, and it's not inferior, but it's a cheaper workforce with far more limited competencies. But that limits the ability to be highly and truly scalable. And this is where AI and technology delivered approaches can actually come in really helpful within a stepped care model. Can we move on to the next slide, please? So this is what I was talking really about, the evidence base currently suggesting we need support for CBT self-help. So this is some research I did with Joe Woodford, a systematic review. And once again, we graded the quality of evidence, and then we looked at what was left in terms of good to very good quality evidence. And there was an advantage for support over self-administered. And there's three types of support. There's guided, which is about 25 to 30 minutes. And this involves the psychological practitioner actually supporting the patient who is experiencing difficulties with some of the specific factors. And they will also encourage the patient to move through the self-help interventions. We have minimal contact. This is 5 to 10 minutes. And this is where the psychological wellbeing practitioner will actually check in to make sure that the patient is progressing through the interventions. And they will offer encouragement, and they will ensure that the patient knows what they're doing in the next session, between sessions, and move them through. And then we have self-administered, where the patient just uses the interventions on their own. If we look at the effect size, then we're looking at a moderate effect size for guided and for minimal contact. Not interestingly, not much difference. So IAPT has adopted the guided model, whereas the minimal contact seems just as effective. But self-administer, we're talking about a minimal effect size. The effect size drops, therefore it justifies the use of support. We could move on, please. Now, what we've also noticed, however, is we've done a systematic review looking at low-intensity cognitive behaviour therapy for medically unexplained symptoms. And something interesting occurred. First of all, we had the guided, the minimal contact, and the self-administered. And we had very much the same pattern of results as we did for depression and anxiety, in that there was a benefit of having support over self-administered. But we also noticed that there was another type of support, and we called that automated. And I think in retrospect, that's not the best name for the type of support. But this is basically support that's being provided by technology. So, and a good example of this was Sleepio. And as we see, we had a very, very large effect size with Sleepio, very much larger than you would normally see. And that may be to do with the sample size in the research, because it was a low research sample size. It wouldn't really allow definitive conclusions. However, the research was of good enough quality otherwise to actually make it into the systematic review. And what they adopted was what they called a virtual therapist. So they had an algorithm that was picking up and driving the amount of support and the usage of the intervention. And that was based on outcomes at baseline, the amount of adherence that the person had to the technological CBT program, and also performance and progress. So the algorithm would obtain this information as the person was using it and feeding the information in. And then it would offer support and advice regarding moving forward, or the best evidence-based CBT technique for that the level of progress. And the CBT techniques, the single strand techniques, was sleep restriction, stimulus control. They had some cognitive techniques, progressive muscle relaxation, and mindfulness. So the app, the interface, the algorithm-driven system was actually getting feedback using the algorithm to help the person move through the use of the technology. If we could move to the next slide, please. So we have actually now, there's been a lot of progress in this area. And there, as was mentioned, there are thousands of apps. There are thousands of systems. One system that I'm aware of, simply because the guys that run this new startup company came to me, and this is I Own a Mind, to really try to understand from a research perspective how we could really enhance and put the effort in to enhance the usability and the effectiveness of the app in which they've developed. So they've developed it for cognitive restructuring, and now I understand they're moving to generalized anxiety disorder, and they're basing it on low-intensity CBT interventions. So they're not making them the high-intensity complex approaches. They're using the evidence about low intensity, and they're trying to use the single-strand CBT technique approach. And the idea here is to replicate the benefits of what we call automated support through an AI chatbot. And what the AI chatbot is able to do is it's able to use common factors to help the patient engage with the intervention. And we know common factors enable effect size to be reached. It's not the only solution, and you can't just use common factors alone, but they're part of the solution. It probably enhances engagement so people get the right dose of treatment. And we know this is currently a limitation because the amount of people that get the right dose of treatment through these technologies is quite minimal. It doesn't engage people. Then what the chatbot is able to do is able to actually offer support around the specific factors of the low-intensity CBT intervention. So it's gaining momentary assessment information back from the person's use, and then it's able to target the specific factors that the person is encountering, and then it's able to offer advice and support the person, just the same as a psychological well-being practitioner would do in terms of face-to-face human support. If we could move on to the next slide, please. So we have a lot of research actually that is beginning to emerge that's suggesting electronically delivered CBT. And I've got the reference there because there's a very good paper that says we need to start using standard terminology, because sometimes we're talking about the same thing: computerized CBT, electronic CBT, mobile CBT, and sometimes it's getting confused with other approaches. But what the research by Loire says is that technology-driven approaches, electronically delivered approaches, are at least as effective as face-to-face CBT. The evidence was of moderate quality, and there was heterogeneity in the data, but it's beginning to suggest we can provide that supported function, which the evidence base suggests you need, but actually we can do it in a way through the use of technologies, such as an app or a CCB, a computerized CBT system, where this technology is built in. In the IAP program, we know digitally enhanced technologies are massively underutilized. There's a lot more out there that are currently being used, and there's over-reliance potentially on the human face-to-face support or telephone support provided by the psychological well-being practitioner. Now, if we look at eCBT solutions, we can potentially enhance the functionality of the intervention by supporting the specific factors. We can potentially reduce delivery costs by actually providing that support within algorithmically driven support functions. This will allow us to promote scalability, and also increasingly these approaches are being seen as acceptable. So it's no longer the case that if we design these well enough that they're not acceptable. However, also picking up on one of the questions, there are concerns. We need to ensure the quality, we need to ensure the security, and indeed the efficacy of, if we're talking about mobile phone apps, we shouldn't be recommending or we shouldn't be using mobile phone apps if we don't put a tick against each of these areas. And the National Institute of Health and Care Excellence are looking at making recommendations around specific apps as much as they're able to, although it is a big undertaking, and at the moment they're not in that position, but they do give guidance on quality and security of mobile phone apps. If we could move to the next slide. So we need to think about considerations, and it was really nice to see a question come up in the previous talk, that if we're thinking about making electronic CBT an asset, it should be well informed, it should be scientifically credible, it should be peer reviewed in publications, and it should be evidence-based. So these, I think, are the minimal criteria. So before we keep pushing the development of more and more apps, we need to start taking a step back and thinking about some of these characteristics before we start recommending the use of any system. If you could move to the next slide, please. So that's basically a bit about where I come from as well. And my email is at the bottom. And if anyone would like to get in touch about anything in my talk or understanding low intensity CBT, because I appreciate this may be new to some of you outside the United Kingdom, then by all means get in touch. And that's my presentation. So thank you very much for listening.
Thank you so much. We do have two questions. One question from the audience and actually from the Church of Sweden. What are the activities at Step 1 in the community you talked about, and what's the target group you're training here?
Okay, so in Step 1, it's very much the use of upskilling members of the community, whether it be charitable groups or particular individuals that are trying to support people. But it's predominantly focused on prevention. It's not focused on treatment. What we're trying to do with Sub-Threshold is offer evidence-based supports, and it may be basic psychoeducational groups. There's an increasing use of some CBT-driven techniques in a way that will actually work for prevention, but they're not being seen as treatment. But it's engaging the community. It's engaging people, community sector organizations, and it's also engaging particular organizations or community groups that work with people with diversity, because we know we need to engage people with diversity, with often members of their own community. So really that's about empowering the community to offer the preventive approaches.
Thank you for that answer. And I know that you've worked with Joanne, that's here with me in the studio, and I think, Joanne, that you have a question also.
Yeah, I have a quick question for you, Paul. So we've spoken a lot about how many, for example, apps are out there. So there's a huge quantity of e-mental health interventions that are available for anyone to download, but really varying quality, varying evidence base, or no evidence base at all. One of the things you mentioned about the idea of having this automated support or having a chatbot, and you mentioned about quality, you mentioned about the evidence base and security, but I just wondered, what are your thoughts about safety, patient safety? That's something we've not touched on so much today.
Yeah, and obviously it has to be a considerable concern. So it's a matter of understanding what makes safety. So, for example, Jo, I guess you might be talking about risk assessments.
Yeah, absolutely. Yeah.
And so we know that, and indeed from our practitioner workforce, we can do very, very good risk assessments. But one of the challenges with using AI is actually acting on the risk assessment once it's done, and once it's flagging that there may be an issue. And actually, in terms of implementation, I think this is potentially a wider consideration. And this is why it's so good to think not only about the apps or the technologies, but how they fit within a wider system. So it may be that as well as having AI or apps, then there needs to be some flagging or notification process that if someone is scoring high on risk, the very least is that they're informed about measures that they can take to manage their risk, potentially maybe notifying someone who's overseeing the use of the app, etc., about that risk and getting them to manage and follow some protocol. But indeed, it's not an easy one, and it's something that hasn't been given enough consideration, I don't think, by anyone, as far as I'm aware.
Okay, thank you.
Thank you. Thank you for that. And I know that you need to leave at 15:15, but let's see if you can stay on for a short discussion later on. So please stay in the meeting for a while.
Yeah, no worries, no problem.
Thank you. Thank you so much. Well, the more we use apps and internet, the more we can work cross borders and take advantage of each other's findings. Now, our next speaker has experiences for both blended treatment and hybrid treatment, where both the internet and the physical treatment are combined. Also working in projects over borders of countries. Now, please welcome Dr. Gerhard Andersson from Linköping University here in Sweden. Välkommen, Gerhard.
Thanks a lot for that, and it's great to follow now these excellent two speakers, and I will do my best to be short and focused. Right, and you see the main conclusion here: psychological internet treatments work and can be exported to other cultures and languages. My starting point here was actually the pandemic. We wrote a little piece about this. You know, these things have really changed in terms of attitudes towards digital solutions. And for a long time, I said this is a complement and sometimes a replacement. For some people now, through these last 1.5 years, it's been the only way to access any form of mental health care. So that's an important thing, important background. What I would like to do now is to tell you a little bit what this is and something about the evidence. I will give you examples of adapted and translated work and some conclusions perhaps about this so-called gap. Internet treatment, what I'm referring to here, for those of you who don't know already, we nowadays, giving broadband access, we can use text and films. It very much resembles online education. So if you've ever done any online course, you would recognize yourself in many of these systems. Indeed, you can transfer them to apps and tablets, but in the end of the day, actually several people who have worked with these systems prefer to sit in front of a sort of larger screen. So apps are not only abundant, but not so popular as you would have expected. As already said by Paul, you know, most of the evidence is for the guided interventions where you have a clinician behind the scenes who give you support when you need it, or even on a scheduled basis. And this support can be done fairly easy, by the way. It's been shown that less skilled practitioners can do it as long as they have supervision. And in terms of research support, there are so many tasks in clinical trials that take enormous amount of time. Usually, those tasks are quicker when you do this online, which means that I don't know if my colleagues agree with me here, but you know, we're approaching the stage when there is more evidence for internet treatments than there is for standard face-to-face treatments. Larger trials, more trials. Odd, how does this happen? One way to summarize the evidence, and this is only possible in fields that are really established, because then you can do something called umbrella review. It sounds like a song by Rihanna, but it's not. It's a way when you have systematic reviews and you can do a review of these systematic reviews. And so we did, and focused on common mental health problems. And yeah, the most recent meta-analysis, systematic reviews. And I'm sure not all of you are familiar with this, but most of you are, and I'll tell you what it means. It means that the so-called effect size here is the difference between getting a treatment and not getting a treatment. Usually, if it's about 0.80, it's really, really good. So now you know. So for panic disorders, when it comes to internet treatments, it's more than good. Social anxiety disorders, same. Generalized anxiety disorders, the same. A little bit less than good. PTSD, even, you know, working with trauma. Many of my clinician colleagues, and I'm a clinician myself, would that seriously doubt if that's possible. Well, at least for not too severe problems, this way of working might do the trick. And again, also major depression, which is a huge problem for society. Also, pretty good effects. I cannot speak this language. It's the Kurdish dialect or language called Sorani, and it's one of our earliest studies when 2 students had this idea of why can't we do this in Kurdish? So we did. It took us some years to get this published, but this is a very basic story. You have a group of people and you get ethics approval, and then you randomize them to getting a treatment or waiting for a little while, and then you provide treatment for them afterwards. Sometimes we give them support, sometimes an alternative treatment, but this is a very good starting point. This is better than getting nothing, which is very often the case. You don't get anything else. So here, their depression scores decreased up to 6-month follow-up, whereas not so much happened for the ones who waited, were in the waitlist control group. And I would briefly touch upon this, but obviously, this is not something I would have been able to do myself. You need to culturally adapt. And these were 2 Kurdish guys who could do that. They were actually on Kurdish television locally here in Sweden. And to make it tailored for that group. You know, just such a thing as a word like depression doesn't mean the same thing in different languages and cultures. Another example, this is still Europe, but it's the former Eastern Europe, where there's not been so much research done, for one reason, not having so much resources. And I think this is probably one of the first controlled trials on social anxiety disorders. There was this guy from Romania who came and visited our lab, and we translated our social anxiety disorder treatment, and he worked with a bunch of colleagues and students in Romania. He really didn't believe in this, to be honest. He was kind of skeptical. People will not like this. But obviously they did. And so we managed to replicate almost exactly what's been seen in other countries in the world, including Switzerland, Australia, Germany, even the UK, large, interesting, unpublished trial on social anxiety disorder that you will see soon, I hope. Right. And we moved on to Arabic language. That's another example here. That was quite a challenge as well. And not the least, you know, in Sweden here we have a substantial immigrant population, many of them being refugees with a refugee background. And I tend to view it like, even if you might know Swedish a bit, Swedish it's not necessarily your emotional language. So at the very least, when these internet treatments or digital treatments, at the very least, you can translate them, you know. And that's our platform we're working on now. It exists in so many languages. This is not my work. This is work from Ireland, and actually a person who's from South America, the first author. But they started working on this. How should we think when we adapt treatments, in this case for Colombia? We cannot just translate them immediately. We need to consider these cultural differences, aspects, and so forth. And that's what we're up to right now here. We're working with young immigrant refugees, and to give one example. Okay, this was a quick one, but I think that was the instructions. I'm open for questions. There are many things you can say about this idea of doing research, helping other people doing research. I think it's been much easier to share, not only data, that's the last point here, but also sorry for this, it's blurred here. Also treatment programs. Back in the days when we used only face-to-face treatments, you had to go there, you had to train clinicians, they had to be certified. Here we can move much quicker and get data to see how well does this treatment work in another setting. I hope it can help reduce the treatment versus demand gap, but also speed up the process of adapting interventions and developing interventions. You know, even if everyone knows what depression is, perhaps, or social anxiety and so forth, but there are many other problems people have. And we've been running trials now on loneliness, for instance. There is not a diagnosis called loneliness disorder, and perhaps we shouldn't have that. But that's a problem that people suffer from. Another is self-esteem, and so we're gradually moving towards those, and very much look forward to culturally adapt and work in other settings and languages for those concepts as well. Right. So I'll end there and look forward to your questions. Thanks a lot for your attention.
Thank you. Thank you so much for sharing all your different projects. One question, what would you say is the most important obstacle to overcome in order to greater share between countries? You talk about culture and language. What would you say is the most important obstacle to overcome?
In terms of research, it's actually the lack of procedures for ethical approval across countries. In theory, we could run a study and include people from all the world. But that is a tricky thing, even within Europe. And I know some people have written about this as well. It's very hard to handle different legal systems. And I think some of the good things with nowadays is protecting people with GDPR, which is for data protection. It was one of the questions, right? And that's very good. But there's also a problem in research if that makes people not even want to touch upon this. The possibility of helping someone from a country in another country. And we've been thinking a lot about this now when we work with immigrants and refugees who might leave the country while being in treatment. So I hope we can solve that in the future. But that's a challenge.
I see, I understand. Thank you so much, and please stay on for the short discussion. And
I will.
Thank you. And now we will go to our last speaker for this session. Now, new digital health tools, I think, will really help many, and it's amazing how fast innovations are growing. But what about the real interaction? What about the human touch and maybe the meeting of eyes as a contrast or maybe as a complement to the digital tools? We're now going to hear about the human-animal interaction as a way of treatment. Welcome, Dr. Andrea Beetz, professor at the International University of Applied Science in Germany. Hi,
Hello,
Andrea.
good afternoon.
Welcome.
Welcome. So, let me just start my presentation. Can you all see it?
I can see it. Very good.
Wonderful. Thank you very much for inviting me to such a highly interesting and needed session for all the new methodologies that you can apply in psychotherapy. The possibilities of the internet are really fascinating, and thank you to my previous speakers. I've used internet now myself as a therapist in psychotherapy to keep in touch with my clients, but usually I do face-to-face, and I've learned a lot today. But what I am going to talk about today is something that really is not compatible with the internet or internet-based therapy, because I'm talking about the benefits of the human-animal interaction for mental health and well-being, and how you can integrate animals into psychotherapy. So something that's called animal-assisted interventions. We know from different studies, actually now there's a good evidence base for that pet ownership has some health effects on humans. For instance, in big surveys, pet owners do have do report less doctor visits, take less medication for sleep problems, for instance, exercise more, they have better subjective fitness. And also, if you look at the survival rate after 1 year after a heart infarction, at least the dog owners do much or significantly better than the not pet or not dog owners. Another short introduction to what are we talking about in terms of what is an animal-assisted intervention. We distinguish between animal-assisted activities. You might have heard about people taking the dogs and visiting nursing homes, just for giving a possibility to pet the dogs and to bring some joy and topic for conversation. Then we have another form that is really animal-assisted therapy. And here a human therapist trained in his profession needs to deliver the therapy, and he or she integrates the animal into their usual approaches. And another field is animal-assisted education, where you have animals integrated into the school lectures or in the afternoon school activities. Also here to prevent mental health problems or just to promote learning experiences. And to give you an impression how this could look like, I'll give you an example from our work and also research. I worked in a project together with the German Bundeswehr to develop a dog-assisted intervention as an adjunct therapy to psychotherapy for soldiers with post-traumatic stress disorder. And we had German soldiers, and each of them participated in a 3-hour session every morning, not every morning, once a week for 4 weeks. They've usually been in in-house treatment for 6 weeks in one of the Bundeswehr Krankenhäusern. And what it looked like was that there was a dog with his handler, and all these teams have been tested for, friendliness and non-aggression and everything. And here the special thing was that it was delivered actually by other soldiers working with their military dog. And each patient got assigned a team, and they just went for a walk, they groomed the dog, they made little games with the dog, nothing aggressive. And also the handlers were instructed not to talk about the trauma, not to talk about the war experiences, just to give them an opportunity to enjoy being with the dog, being outside, and enjoy the contact. And this was, of course, in addition to the standard psychotherapeutic treatment that they received. But these sessions were talked about in group therapy sessions that followed on the next day. What we found, and this is also has been published, you will see the reference in the last slide, that what was very important is that there was a good relationship developing between the dog, between the patient and the dog and the handler. The soldiers with post-traumatic stress disorder, there's a lot of distrust towards other people. There's a lot of anxiety and stress. Being outside often is very challenging, and especially the surrounding where they had the therapy delivered. There was a military base nearby, and the jets sometimes flew over this area. And what they reported, even besides all the data that we collected, was really important from the view of a therapist. It was first that they actually had the experience of being able to trust someone again, and this translated also to other humans. Also that they were able to relax being around someone else, being around the dog, and that they had fun. Many of them said it was the first time I was able to laugh again. Because in psychotherapy, we all know what bad experiences our clients have made. Sometimes it's difficult to find something to joke about. It seems inappropriate. But if the dog does something funny, you never think it's inappropriate, and you feel free to laugh and to make jokes about it. And maybe here's one sentence that you can see that one of our patients said. It was the first time in years that I could not only tolerate, but enjoy the physical contact with another being and relax. Even the jets did not trigger anything. I just focused on Gina, that was the name of the dog. And this physical contact really is something that is so normal and usual in animal-assisted interventions. But it's very special in psychotherapy, where you usually, when you learn or train how to be a psychotherapist, you are told, do not touch your patients. But we know about the mechanisms that happen and how this can enhance building trust with the animal, because with the animal, the touch is not regulated by any kind of societal expectations. But with other humans, if you would just touch your PTSD patients, that would probably even increase their stress and not be helpful. So let me proceed to some other information about animal-assisted psychotherapy. You will find many different species in this area. Very common is the employment of dogs and horses in therapeutic riding, but we also have therapists that work with farm animal species like chicken, sheep, goats, donkeys, pigs, cows. So they usually have a little farm and they deliver the psychotherapy in the surrounding. Also, llamas and alpacas have become very popular. They're very sensitive in the interactions. And you can also find small animals like guinea pigs or rabbits. It's usually more for feeding than for petting. And there are different approaches. For instance, it can be a form of adjunct therapy where there's a standard treatment and you just have the possibility for certain experiences like relaxation, touch, cuddling, of being accepted, it doesn't feel like therapy, but it's still very good for the mental well-being of the patient. And sometimes it sets the stage for the actual treatment, like reducing stress before a trauma therapy or providing social support by having the dog there. And then the other approach is actually having the animal present during the psychotherapy. Many psychotherapists now work with animals. And so the dog is present the whole session, for instance. And while you're talking about stressful events, you can pet the dog, and this usually reduces your stress and makes you feel more safe. What are the effects that have been documented by research, by experimental studies, randomized controlled trials for persons who have no mental health problems, but also for persons with mental health problems, children, adults, and elderly? On a physiological level, we have documented in many studies that there's a reduction of stress, heart rate drops, blood pressure drops, cortisol levels drop, and this is mainly due to the activation of the oxytocin system via touch. Oxytocin is a hormone that regulates the whole system for calmness, connectedness, and it also counteracts stress reactions. Then we have psychological effects. It reduces depression and anxiety and promotes a positive mood, relaxation, concentration, and attention. All things that you would like to see in a psychotherapeutic setting. And it promotes in the social area the communication, social interaction, and trust. And it reduces aggression. And all of this can happen if you integrate an animal into this therapy, or it makes it easier for the therapist to reach these goals. Also human therapists, of course, can work towards reducing stress, building trust. But our experience is that if you integrate an animal, this is established quicker and often easier. What are the mechanisms underlying these effects? For once, biophilia. Humans have always lived during the evolution together with animals in natural surroundings, and so it was had a survival effect for us. The biological fitness was better if you paid attention to animals. They could be a source of food, but they also could be a source of danger, or they could warn you about dangers. So if an animal is in your presence and this is a friendly, non-threatening animal that is calm and relaxed, this is obviously an unconscious cue for the patient that it's a safe surrounding and that he or she can relax. On the other hand, we are interested in animals due to the biophilia. So this is also motivating clients to attend therapy. For the soldiers, for instance, we had some patients who were really, we call it in Germany, therapiemüde. They are tired of yet another therapy. And with the dogs, all people were quite happy to go on the bus to be brought to the dog school of the military. there, and they participated very freely and openly. So we see a lot of motivation build up. And it can lead to an optimal activation of the patient. If he's too stressed, the animals calm them down. If they are too tired and not motivated, they are activated. And as I said before, touch, and via the touch, the activation of the oxytocin system might be a key variable here, because there are 5 to 6 studies that show that petting a dog even for 2 to 3 minutes only gives peaks in oxytocin release in the brain. Also, patients tend to develop something called openness to securely relate to others, to the therapist mainly, to build a therapeutic relationship. And animals also provide support, especially when you've built trust and attachment to them, and they give you a possibility for caregiving, to feel needed, to be able to provide something for another being, while before you always felt you're full of deficits, you cannot do anything for anyone. So, and this is a good opportunity to let patients take care of animals and feel important and needed. Due to the pandemic, we have some new research areas also in animal-assisted interventions. For once, the role of pets during the pandemic and how this positively affected mental health if you owned an animal, and many people acquired an animal during that time. But also for the implementation of animal-assisted therapies, of course, it became much more complicated due to hygiene issues to deliver animal-assisted interventions. There are some of the references, there are much more, and if you have any questions, please feel free to contact me via the email address, and thank you very much for your attention.
Thank you, Andrea. Thank you very much. This is very interesting. Can I ask you, what kind of reactions do you get from different countries? How mature are the different countries for this method?
Well, it's, for instance, certain approaches like school dogs or also integrating animals in psychotherapy are more common in Germany, Austria, Switzerland, and the Netherlands. But I have the feeling in the Scandinavian countries, it's just starting. It's more difficult to implement this. But also in the United States, it's very popular by now to integrate animals in different therapeutic and educational approaches.
I have a question also from the audience. What criteria sets the choice of an animal for psychotherapy?
Oh, that's a good question, because there are so many different species, and it depends on what kind of setting you have. If you're a psychotherapist and you have a dog and this dog is suitable and you train it, usually people say, oh, the dog is my animal of choice. If you are someone who is it depends really on the therapist. What kind of animal do you prefer? Because you have to be able to connect with the animal and work very, very fine-tuned with the animal. And then also it often depends more on the individual and on the personality of the animal than on what kind of species it is. There are some people who relate nicely to cats. On the other hand, cats are difficult because many people are allergic to them if you use them in a standard psychotherapeutic setting. So this is really a match between therapist and the choice of his animal or animals that he has, and then choosing what is best for the patient. And certainly there are some things that, for instance, you can only achieve, for instance, with a horse. If it's about, body posture, like more physiotherapy, then the horse is the animal of the choice, because you can sit on the animal and it imitates the human gait when it's moving. And there's no other animal where you can do the physiotherapy on the horse like that. Or being carried by someone, being, if this is the feeling where you are supposed to feel your body and really relate to that. For instance, if you have an eating disorder, and to feel yourself again after a trauma. Also there, the horse has some advantages because it's so big and you have so much physical contact with it by riding.
Thank you. I've read about the robot animals working with mental well-being for senior citizens in their homes, for example. Yeah. Would you say that this is a bridge between the digital innovations that we talked about earlier and the therapy that you do? Does it work? Do you know?
It certainly is a link, and I know that there have been studies with the RoboDog Aibo, and there's a seal called Paro that they use in nursing homes. And yes, actually, it does have positive effects. Some studies have compared it to live animals. I'm not sure. I hope the live animals won, because I would say there's still another feedback that you get from a live animal, but the electronic animals are better than no animals, because they have a very soft fur. They give you some reactions, when you pet them the right way. And obviously, some people are very, it's like a stuffed animal. When you had an attachment to a stuffed animal as a child, and some people really get attached to this little robot seal. But I think the live animals really do have more advantages. I still would like to see some research petting the robot seal, and if you get any oxytocin peaks. I hope not.
Well, we'll see.
No, actually, it would be good, because it's no animal protection problems with that. No animal welfare problems with the.
And maybe no allergies and stuff like that either. So
no allergies, yeah.
We'll see if someone will do a study on this. Now, let's see how many we have in the meeting. I think maybe that Paul had to leave. Let's see if we're all here together for. We can do one question, I think, because time is running short on us. But if I ask all of you still in the meeting, what do you see on the horizon when it comes to mental health development in this discipline, undergoing tremendous innovations in different fields? And what do you see on the horizon if you look ahead a few years? What can you imagine will happen? I will ask all of you. Paul, I'll start with you, because I know that you need to leave later on. What do you see in the future?
I think we'll just start through more sophisticated algorithms, through better machine learning. We'll start to understand a little bit more about human behavior, about what's working for whom. We've always had this what works for whom element, and dismantling studies are particularly difficult to do. So I think we will start to understand what we need to actually refine AI-driven approaches even more. And as such, I think we'll just take the field more further forward.
Thank you. Thank you. What do you say, Andy? What do you see in the future to come?
Well, I think engagement is a big area that we need to really focus on. And I think sometimes I think there are really exciting applications of natural language understanding, for example, in helping people to express the problems that they're experiencing, and the recommendations that might be made to a person could be more personalized. And I think that will help with the extent to which people are able to engage with these systems and get the right dose and receive a benefit. I hope also that we'll see a shift, not to the exclusion of small-scale, intensive research studies, because of course they are necessary and absolutely vital. But I think we'll start to see really interesting studies being born out of very large cohorts of people undergoing treatment, and so we can sort of learn and translate as we go in faster cycles. So I suppose that's my aspiration. Someone mentioned to me that it took 49 years from the first paper on CBT being published to it being embedded in clinical guidance in the US. But so I hope we can maybe learn and translate in fast cycles using real world data and good scientific practice.
Speed up that process a bit and not wait 49 years again. Thank you. Gerhard, what do you say?
Yeah, I'm still a believer in the experimental method and in good science, that we can work together from different disciplines in science to improve interventions. I'm not that convinced yet that machine learning will do the trick, but perhaps in combination with experimental methods, then I'm much more in favor. And I also strongly believe that we need to consider our customers or our patients. Sometimes they do a better job than we do by asking them, what would you like? We actually did a trial showing that patients could choose different CBT components from their own will out of 15. And in one trial, that worked better than if we decided for them. Obviously, there's pros and cons of that, but I'm just saying that we need to go to our patients as well, and not only to our machines, or perhaps both. Yeah.
Perhaps both would be a good combination, I guess. Andrea, what do you say within your field? What do you see ahead?
Well, overall, I would hope that there's much more diversity in the offers of psychotherapy, so that it could be more individualized. You know, what every person is different, and so also people would need different approaches. You know, and it would be great to have algorithms to figure out which is the best fit for whom, but also asking the patient, because sometimes they know quite well what they would profit from. And so I would hope that it's more variety, more different offers. Some would prefer online treatments, some really want the face-to-face or the interaction with an animal. So just have a wider array of possibilities, and having it more personalized. I think that's really a key issue, not only in psychotherapy, also in medicine now.
Yeah, thank you. A wider range and more to choose from, perhaps. And Joanne, what do you say? What do you see in the future?
Yeah, there are two main things that I was thinking about. One was actually linked to what Gerhard was saying. I also believe in robust experimental methods, but also technology develops really quickly. And if we're working closely with users, if we're trying to meet their expectations, that is often goes out of fashion quite quickly. So it would be good to see further developments in the way in which we can use robust experimental designs, but faster but quicker. And then the other key piece, which I feel is always missing, is that we do a lot of research in artificial academic settings, and we don't really think about the context of implementation enough. So how can we better organize services? How can we develop workforces to support, to guide these sorts of interventions? How we can think about how systems can integrate better, and so forth. So I think those two areas, there's a lot to do.
Thank you. Thank you so much. Thanks for being with me here today, Joanne, and thank you so much to all our speakers today. Thanks for being with us, and thank you to all the participants as well, of course. Now, we will soon have a short break, and then for all of you registered for the workshops, your work starts at 3:30 Swedish time. You'll have to figure out what it is where you are, but at 3:30 you need to be in your workshop links that you have got when you registered for that. And those of us who are not joining the workshops, we will get a short summary on Thursday on that job and the reports from the workshops. Tomorrow we will talk about mental health of the adolescents and also the effects of social media. So that will be very interesting as well. So have a good workshop, and the rest of us will see tomorrow at 2 o'clock Swedish time. But bye for now.